Good afternoon, everyone. Welcome to the first NCAI Tribal Data webinar. This is Malia Villegas, Director of the Policy Research Center, and we'd like to welcome you to our first effort here. We're very excited to welcome Dr. Joan O'Connell, who I'll introduce here in just a moment. But before we get started, we wanted to take you through a few aspects of the webinar interface for those of you who may be somewhat unfamiliar with GoToWebinar. So I'll send it over to Sarah, who's going to walk us through a few of the features.
Hi, everyone. So what you see on the slide here in the viewer pane is basically our webinar system and how it is made up of two parts. We have the viewer window to the left and the control panel to the right. So what we're really going to focus in on is the control panel, and that will help us understand how the system works and how you can participate in today's web event. So we'll head to the next slide here. So first, we'll just show you real quick how you can open and close your control panel so you can be able to see the screen more effectively, so that you simply touch that red arrow in the top left corner. The next thing that we'll focus in on here is the audio pane, and if any of you are having difficulty hearing us, we'll want to make sure that you can view, select, and test your audio. So some of you may be connected through your computer system, and that will show you that you are using your mic and speakers. However, if you would prefer to connect with us via telephone, then you would select Use Telephone, and then this individualized pane will pop up that will allow you to dial into that number, enter the access code, and then it issues you a unique audio PIN. And if you would like to ask questions over the course of the webinar, we'll have a Q&A session towards the end and somewhat interspersed in between. We will unmute your line. As you'll notice, everyone is currently muted to avoid background interference and noise. We will unmute your line, but you will need to have that audio PIN enabled in order for us to hear you and your question. Another way that we can kind of have your participation gauged throughout this session is by raising your hand. So you'll see that function over to the left as well. Just feel free to raise your hand if you have questions, and also make use of the question pane chat box and enter any questions or concerns that you may have there. Again, we will have discussion during this session. We're looking forward to really digging into this new Indian country health database, and we are recording this webinar, and it will be made available, and we'll send out some more information to you within 24 hours of this webinar session so that you'll have a link to the presentation and its recording online. So thank you again for joining us today. I'll hand it back to Malia.
Wonderful. Thank you so much, Sarah. So although this is our first tribal data webinar, we have had a series of quarterly tribal data teleconferences that, like this webinar, are open to all. And we want to certainly encourage those of you to reach out to us if you have an interest in participating in those going forward. But it's a part of NCI's mission and the mission of the Policy Research Center to provide tribal leaders with the best information and knowledge to inform their decision making within a framework of native wisdom to ensure the best futures for our people. And so, as I said, we're very excited to have a scholar who's somewhat new to us, but perhaps not new to some of you out there in the field, who's been doing some amazing work, Dr. Joan O'Connell. She is a health economist at the Centers for American Indian and Alaska Native Health, where she also serves as an associate professor at the Colorado School of Public Health. She's had an extensive set of experience with large data sets, helping to build community capacity around data use and analysis. And we first learned about Dr. O'Connell at our Diabetes Data Institute this past July in Seattle from one of her colleagues, Dr. Spiro Manson. So we're so excited that she was able to spend some time with us today. I believe we're going to have about a 30 to 45-minute presentation where she's going to talk across at least three different projects, and then some opportunity for some Q&A, and also hearing from some of you around the network about how this connects and is relevant to the work that you're leading. So I want to welcome Dr. Joan O'Connell. Thank you so much for your time and willingness to share in your leadership in this arena. Dr. O'Connell, we'll go ahead and pass it over to you. Dr. O'Connell, can you hear me?
Yes, thank you. Sorry about that.
No worries.
I'd like to thank you for the opportunity, both NCAI and you as a group, to share with you some of the work that I have been conducting in collaboration with tribal organizations, the Indian Health Service, and other organizations, including governmental organizations and state organizations, on the health needs of American Indian and Alaska Native peoples. I'd like to first tell you a little bit about the center where I work before describing some of the data that I work with. And I sit at the Centers for American Indian and Alaska Native Health, and our center is pictured on the first slide. The center was founded over 25 years ago by the director, Spiro Manson, who is a medical anthropologist and has addressed the health needs of persons with behavioral health disorders, chronic conditions such as diabetes and heart disease, and oral health, as well as many other critical health needs of American Indian and Alaska Native peoples. I've been at the center for well over, maybe close to 15 years, and we are currently located in the Colorado School of Health at the University of Colorado, just outside of Denver. And what I thought I'd do today is review a number of the different projects and provide some highlights that I have been working on in collaboration with the National Indian Health Board and the California Rural Indian Health Board. We work together to provide information for the Center for Medicare and Medicaid Services Tribal Technical Advisory Group through the TTab Data Project. And as you can see on this overview slide, I thought I'd share some highlights of 4 projects I have worked on as part of this one project. And then I thought I'd wrap up the presentation by sharing with you information about a diabetes project that's called the Improving Healthcare Delivery Data Project, which is funded by the Patient-Centered Outcomes Research Institute. And given that we have an hour and a half for this seminar, what I thought I'd do is share some information about one project, and we can stop and have a discussion and then move on to the next. And then we can end the seminar with additional questions that may look back over the information that's been presented. And would that work with participants in the conference?
Yes, it'll be great.
All right. So the projects I wanted to provide an overview of today start out with the first project, which talks about changes in healthcare coverage after implementation of the Affordable Care Act. And the second one has to do with a similar topic, looking at enrollment in qualified health plans through the federally facilitated marketplace. Both address healthcare coverage changes over the past few years. Then I'd like to move on to a Medicare project and then a Medicaid project. All 4 of these projects are part of the CMS TTab Data Project, as I mentioned before. And finally, we'll wrap up with the Diabetes Project. I'd like to provide you some background on the CMS TTab Data Project. CMS established the Tribal Technical Advisory Group, or TTab, in 2004 so that tribes could provide input and advice to CMS on programs and policies that influence the American Indian and Alaska Native community. Because CMS addresses issues related to Medicare, Medicaid, child health insurance programs, and implementation of the Affordable Care Act, the Data Project addresses these topics as well. So the first project I'd like to share with you has to do with our evaluation of data from the American Community Survey. We used data from this survey for American Indian Alaska Native persons who lived in approximately 35 states who reported that they had access to Indian Health Service or tribal health programs. We compared their health care coverage to people who self-reported that they were non-Hispanic white, and we looked at health care coverage before implementation of the Affordable Care Act in 2013, and then after the Affordable Care Act implementation in 2014. First, I thought I'd provide you some information about healthcare coverage for persons of all ages and how it changed between 2013 and 2014. On the left of this part of the slide, we see there's a bar graph that includes information from all 35 states. And we picked those 35 states since they are located, those states have IHS or tribal healthcare programs or are located near those programs. On the right, we have information in this slide for persons who lived in the Medicaid expansion states. Out of the 35 states, 15 expanded Medicaid eligibility in 2014. As you can see on the slide, the Medicaid enrollment for persons who lived, American Indian, Alaska Native persons who lived in these 35 states went up slightly. However, it wasn't a significant change between those 2 years. When we looked at private sector coverage, enrollment went from 32 to 34%, and when we did regression analysis and controlled for changes in the population's age and gender and income level between those 2 years, we found that this difference was statistically significant. Most importantly, we saw that the percentage of persons who had no coverage, that is, they were uninsured, decreased. In 2013, the blue bar, 35% of the American Indian, Alaska Native persons in the 35 states reported that they had no form of health care coverage. That decreased to 32%, a statistically significant change, as indicated by the star, in 2014. In the Medicaid expansion states, we saw some increases in coverage in Medicaid and private coverage. That would be the qualified health plans would fall under private coverage. And we see in those states the percentage of persons who were uninsured or reported no coverage decreased from 33% to 28%. So you can see this drop was larger than the drop in all 35 states. Any questions about these data before I move on to showing you information on the findings for selected age groups?
Hi, Dr. O'Connell. Question from one of our participants, Jacob Davis. I'm going to go ahead and share that. The question is, was there any data collected regarding health coverage for AIAN that did not have IHS/tribal access?
Yes. And we compiled that data separately in the report that will be coming out later this year. First, we looked at persons who self-reported race as American Indian, Alaska Native, either alone or in combination with another race. And then we looked at persons who reported access to IHS services. And then we combined the two groups.
Thank you so much.
Thank you. And I should say we combined the two groups and only took persons included in our sample who reported both race as American Indian, Alaska Native, and access to IHS services. All right, then, let's move on to the next slide. And in this slide, we looked at health coverage among youth. And one thing I wanted to stop and just make a note of, we're using data from the American Community Survey. And in any one year, the number of American Indian Alaska Native respondents is approximately, I think, about 30 to 40,000. And by the time we limit our sample to those who report access to IHS services, it's about 20,000. And although that sounds like a large number, these people live throughout the country. And so the sample size is relatively small for 2013 and 2014 when we look at each year alone. You know, as future years of the data come out and we analyze those data, we'll have additional data that we can use to better assess health coverage changes. So some of the findings you see in these bar graphs that I'm showing you don't reach a statistically significant change between 2013 and 2014. However, as we include more years of data after implementation of the Affordable Care Act, we might see that some of these changes are statistically significant. When we looked at youth, we can see some nice trends in that we see some private sector coverage increase in all states. We see levels of uninsurance decrease, but those are not statistically significant changes. When we just look at the Medicaid expansion states, we see some nice trends as well. And the number of the sample size for the youth in this survey is fairly small. We see some indications of coverage in Medicaid increasing from 55 to 58. However, that is not statistically significant. However, when you take increases in Medicaid, combine them with some increases in private sector coverage, you can see that that can help result in decreases in the percent of youth who are uninsured. In 2013, it was 23%, and that decreased to 19% in 2014. And this change was found to be statistically significant. Any questions?
Dr. O'Connell, there was a quick clarifying question as to where are urban Indian populations represented in any of these data, and if not, are there data that would help kind of represent their experiences with respect to accessing healthcare?
Yes, there are data from Arizona, Alaska, and other states that would include urban areas.
Okay, thank you very much. Did you find the rate of uninsured youth higher for those with access to IHS by any chance? Youth versus their age group?
Yeah, so our sample includes American Indian, Alaska Native persons who reported race as American Indian, or Alaska Native, alone or in combination with another race, and also reported access to IHS services.
Okay.
So all of these youth met those two criteria.
And then one final question on just kind of before you move on, would it, because of kind of some of the limitations with ACS and how those data are collected at an individual level, are there a way to kind of determine coverage by tribes if you look at the level of that unit of analysis?
I believe with more years of data, it's possible to look at one state and have a statistically relevant sample that you could look at changes over time. And that might be one way to address that. Another way, let's see, could be to, use data from the Indian Health Service because the IHS direct sites, the tribal health programs, and the urban Indian clinics upload data to the IHS National Data Warehouse. And then within those data, there's information by tribes that could be extracted and potentially looked at over time.
Okay. Great. Thank you so much, and thank you to the participants who keep generating these questions.
Okay, well, let's look at adults age 18 to 64. And as you can just see from this graph, there's more statistically significant changes. And this is where we anticipate we might see those changes. We know that a lot of the youth who lived in lower income houses may have already qualified and enrolled in Medicaid, and yet that was not the option for many adults. And here you can see on this bar graph on the left that Medicaid enrollment increased significantly. It was 20% in 2013, up to 23%. We see healthcare coverage increased from 34% to 37%. And we see that the percentage of adults who were not insured decreased from 45% to 40%. And all of those changes were statistically significant. Now, we would anticipate when we go to the Medicaid expansion states, where we've limited the number of states we're looking at, we would anticipate seeing a higher percent change in Medicaid enrollment, and we do see that, 26% up to 30%. And we would anticipate, based on Medicaid enrollment changes, that we might see a larger difference in the percentage who are uninsured. And we do see that. In 2013, 43% were uninsured, and that decreased to 36%. Any questions about the adult data?
There was one quick question about how many surveys were generated and returned, just to kind of get a...
Right. Yeah, this is an important question. During the years these data were collected, I wonder if any of the participants have had experience of filling out the survey recently. But there are various ways that someone can respond to complete the survey. You know, say they get a letter in the mail, they can go online, they can respond by mail. But during these years, it wasn't similar to the decennial census, where persons actually went to a person's house to encourage their response. And so our feeling is that the ability for lower income households who lived in more rural areas might have been less likely to respond to the survey than higher income families that lived in urban areas. And that the survey takes into account this under-response by assigning weights, so that ultimately, by the time the responses are weighted to account for the under-response of some people, that they reflect the entire population. But my feeling is that as we take a subset of American Indian Alaska Native data and look at 1 year, that the underreporting might have biased these data somewhat, and that in future years the data will be stronger because additional ways of responding to the survey are available.
Wonderful. Thank you so much for that. We have no further questions at this time.
Okay, well, let's look at ANI, American Indian Alaska Native Elders, or persons over the age of 65. And according to these data, as you can see in the slide on the left, a very high percentage, roughly 95%, self-reported that they had Medicare coverage. And I know that might seem high to some people who serve this population. But remember, this doesn't mean that they had Medicare Part B or for outpatient services or Part T for drugs. This could be just Part A coverage. And we were particularly interested in looking at this age group because we thought that Medicaid expansion can play a significant role in increasing access to coverage to a more wider array of services through Medicaid than a person might have via Medicare alone. However, the number of respondents in this age group is fairly small, and although we see some nice trends in that Medicaid enrollment in the expansion states increased from 28 to 31%, you know, it wasn't a statistically significant change. So we'll keep looking at these data with data from later years like 2015. Any questions about data for this age group?
At the time, we don't have any questions. There was one clarifying question just applies to all ACS. Were the data analyzed here for AIN alone or in combination?
We did alone or in combination. And then for the bar graphs I'm presenting today, we took a subset of those respondents. We only analyzed the data for persons who responded that they had access to IHS services. But the report that we will be issuing later this fall will have information for persons who self-reported race alone or in combination.
Okay, thank you.
Good. Good. I can see some people are very familiar with the survey. All right then. So over the summer in the American Journal of Public Health, there was an article that looked at changes in healthcare coverage among non-Hispanic whites, which are referred to white in this bar graph, African Americans, which were referred to as black, based on the way the authors categorized their data, and persons who reported being Hispanic and citizens. And so we decided we would compare the data for the American Indian Alaska Native respondents that we analyzed to the data in this published article. And they included information for persons aged 18 to 64, so we compared our findings for the same age group, so non-elderly adults. And as you can see in the bar graph on the left, the American Indian Alaska Native non-elderly adults, in 2013, 45%, and this is data for all 35 states, by the way, reported having no coverage. They were uninsured. And that's the number we saw earlier. And in 2014, that decreased to 40%. So roughly a decrease to 5%. You can see that fewer whites were uninsured in between 2013 and 2014. A lower percent were uninsured. That means more people had coverage. We saw similar trends for the African American population and the Hispanic population. They started out in 2013 with a higher percent being uninsured, 126% and 128%, but both had changes. And because each of these populations started at different points in 2013, with the American Indian Alaska Native population having the highest percentage of persons uninsured, we looked at the percent change between 2013 and 2014. The percent change for the American Indian Alaska Native population was 10%, and it was roughly 20% to 24% for the other three race ethnicities. And in summary, we feel that although there was a nice decrease in healthcare coverage in the American Indian Alaska Native population, a decrease in those who were uninsured, the percent change in being uninsured wasn't as large as that seen in these other racial ethnic populations. Any thoughts about the findings presented here?
We have a question as to whether or not changes in coverage levels were identified in this report, and are changes in out-of-pocket copays for doctor visits or pharmaceuticals easily identified?
No, you would have to look at something else to look at those data. Yeah. The value of the, I'm sorry. I was going to say the value of these data are that they include information on household composition, education, income, and other characteristics that can be used to further assess and evaluate who has coverage and who doesn't. For example, when we looked at the data for the youth, we looked at youth who lived in households that reported having incomes that were at approximately 100% of the federal poverty level or below. So chances are those youth already qualified for Medicaid, but in the survey they weren't reported as enrolled. And so, we can also use these data to look at opportunities where there might be potential for increasing enrollment in coverage where people aren't currently enrolled.
Okay.
It's just it's not health insurance data, and therefore we don't have the richness that data would have on coverage levels.
Okay. So the data would speak to whether, since the implementation of the ACA, IHS and tribal coverage has maybe dropped, or are there any trends that you can speak to that way?
So here we're seeing the percent who were uninsured went down. So it was 45% were uninsured, and then it decreased to 40% among the non-elderly adults. So that means coverage increased. Some of that was due to increases in Medicaid coverage due to Medicaid expansion.
Right.
Some of that was due to increases in private coverage.
Okay. Perfect. Yeah, I think they were curious about the drilling down to the IHS and tribal coverage, how that was impacted. So, yeah, that was helpful. Thank you so much. We have no further questions at this time.
Okay. So, we just talked about some of the pros and cons of this data set. We're able to use data from the respondents to make national estimates, which is a benefit. We can look across different states, but there are some limitations with regard to types of coverage in terms of copays, deductibles, and, for example, like with Medicare, did they have Part A or Part B and D as well? So let's look at another source of data next. But before, here are some policy implications that summarize some of the things we've just talked about. In that the changes in healthcare coverage, we saw some increases in healthcare coverage. In other words, the percent who are uninsured decreased. So between 2013 and 2014, when we look at persons of all ages, the percent who are uninsured decreased from 35% to 32%. We saw larger changes for adults who were 18 to 64 years, and particularly for those who lived in Medicaid expansion states. And then we also saw that while these healthcare coverage changes were in the right direction, they were positive, the percent increase was smaller than that in other racial ethnic populations. So it's important that policy and services implemented to increase healthcare coverage continue to be evaluated and enhanced to ensure that the American Indian and Alaska Native community fully benefit from the protections afforded them through the Affordable Care Act and other federal statutes. So let's next look at data that's collected through CMS, through the Center for Consumer Information and Insurance Oversight. The acronym is CIO. They oversee implementation of the Affordable Care Act and the federally facilitated marketplace that people use throughout the United States to enroll in healthcare coverage, except if their state has a state-run marketplace like California, Colorado, Connecticut. So some provisions related to the American Indian Alaska Native community are that tribal members may enroll in a qualified health plan or private coverage that involves a zero or limited cost sharing plan. This means that they don't have to pay the co-pays or deductibles if they're tribal members and they have a referral through contract health services, or what we know as purchased and referred care now, or from their tribal program. In addition, we know that the Affordable Care Act offers tax subsidies to reduce the premium costs for low-income households. So again, the American Indian, Alaska Native persons who live in lower income households can benefit from this Affordable Care Act provision and not pay the full cost of a premium. So as part of the CMS TTAB data project, we work with CMS to obtain information from the federally facilitated marketplace for persons who are tribal members or persons who are eligible for IHS services. And since 2014, CMS, via the organization SOCIO, has provided us enrollment data. And in this slide, I present the data that was most recently provided us for 2015, the end of the year. It's enrollment as of December 2015, and then enrollment as of May 2016. And so if we look at the bottom number, we see that in 2015, in December, approximately 47,000 American Indian or Alaska Native persons who were either a tribal member or eligible for IHS services enrolled in a qualified health plan. This number excludes American Indian and Alaska Native persons who self-report race as American Indian or Alaska Native, but either are not tribal members or are not eligible for IHS provided services. In 2016, we can see this number increased to roughly 55,000. And in the slide, you can see the breakouts, whether people were tribal members or lived in households where one person was eligible for IHS. We know there are some issues, some very serious issues with the Affordable Care Act with the definition of who is Indian and who would be eligible, therefore, as a tribal member for enrollment in zero and limited cost sharing plans. One thing we can look at with these data are who actually was able to enroll in a zero or limited cost sharing plan. So that would answer some of the information someone asked about type of coverage with regard to copays and deductibles. And we're also able to look at the level of coverage they pick. For example, did they pick a bronze plan that had higher copays, deductibles, but also cost less per month versus a silver or gold plan where the copays and deductibles were less, but the monthly premiums were more, as well as some basic demographic characteristics such as age and gender and location. So these are another source of data that don't provide a full picture because we really aren't able to use them to look at Medicaid enrollment changes, but it does provide, these data do provide some details about private sector coverage changes through the marketplace, the federal marketplace. Any questions or thoughts about this particular data set?
Dr. Joan, there's a quick question as to how the population size was obtained, both for tribal members only and those that are IHS eligible.
Great, good question. So on the application, people can indicate their tribal status and or their status with regard to eligibility for IHS. So it's through those responses that the data are compiled. And so people who reported that they were a tribal member and therefore qualify for zero or limited cost sharing would have to follow up their self-reported tribal status with some verification that they were a tribal member. And then they would either be in the top row in that they were on an application where all the members, all the people on that application were tribal members, or it could be potentially that on an application you can have a family where one person was a tribal member and one person wasn't. And then they would be in category number 2. If persons were not tribal members but reported IHS eligibility, if all persons on the application had that status, they would be in this category 3 in this row. And if just maybe one or two people on the application or family members had eligibility for IHS services and others didn't, they would fall into this fourth category here.
Thank you so much for that. And there's another question. Are these are reflecting total enrollees, not just new applicants, is that correct?
This is a point-in-time snapshot of who is enrolled at this point in time. And I know one of the many concerns of people who work with persons that are enrolling in these plans is that someone might enroll in, say, a qualified health plan. And as their income changes through the year, they may or may not choose to continue paying the premium costs for that plan. So there's movement throughout the year where people might enroll and then disenroll.
Okay, yeah, that makes sense. Thank you.
So the actual number of persons who enrolled in 2016 will be much higher than 55,000 as either continuing their coverage from 2015 or starting coverage new in 2016.
I see. And were any of these applications processed as group enrollments? Were tribes able to enroll the entirety of their members, or was it all individual?
Right, there is. We do know when we look at certain states that some of the tribes in those states are paying for the cost of coverage for their tribal members. But we don't have, in the data that SOCIO is providing us, these summary data sets, the number for whom that was the case. The Tribal Technical Advisory Group has requested from SOCIO that additional data be provided. And to date, we haven't had information on some of those types of data available yet.
Okay, perfect.
But
were there any concerns in administering the survey around participant literacy, with certain questions proving to be more challenging to obtain, clear responses to than others, or was it,
Yeah, that is a good question. These are enrollment data from persons' enrollment applications. And so I know it can be difficult to enroll online by phone, and that many people do use enrollment counselors to help them with that. And I know that funding to make available enrollment counselors in various locations, at the hours that people come into healthcare facilities or other organizations, can really influence the number of people who can enroll.
Okay, perfect.
So we've just looked at two types of data to assess changes in coverage. And we know that many organizations, both at the IHS facilities, the tribal health programs, other tribal organizations, are working hard to ensure that persons who qualify for these benefits are able to enroll should they choose to do so. But we can see that there are limitations of each of the data sets that I have provided to you, right? One has more information on coverage than the other. The federally facilitated marketplace data, however, it doesn't have the Medicaid enrollment data. The American Community Survey is not as rich in terms of the types of coverage people have. So another source of data would be data that's compiled either by a state Medicaid program, where you can look at enrollment by eligibility category. Another data source might be the Indian Health Service data, the National Data Warehouse that the Indian Health Service runs. They have data for across the United States, and they would have information on people who have Medicare, Medicaid, private sector coverage, and again, they would have data across years. And so that is a data set that can be looked at to also look at healthcare coverage changes. So I think, when we're thinking about what kinds of questions we want to answer, in terms of healthcare coverage changes since implementation of the Affordable Care Act, there are a variety of data sources, and each has various strengths and weaknesses.
Wonderful, thank you. And there was another question, kind of in the future, could a system be developed to gather data sets through a template made available to clinics and hospitals on tribal land? Maybe.
I think, when I think about that, I always feel it's a little bit more difficult to collect new data than it is to use existing data. And so my preference would be to first tap into the data at the Indian Health Service and the National Data Warehouse, see what's learned from that before going in greater detail to sites. However, so that would be my thought. Unless maybe there's a large site and they know that certain tribes within their site are sponsoring the premium costs, they could answer certain questions they have about that particular effort using data from just one site. So it really depends on your research question.
Absolutely. Thank you so much. There are no further questions at this time.
Okay. Well, good. Well, let's move on to another project that we've worked on through the CMS TTAG data project. And just to remind you all, the CMS actually provides funding to the National Indian Health Board, and then via a subcontract to the California Indian Health Board, and then via subcontract to my group at the Centers for American Indian Alaska Native Health. So we work together, NIHB and CRIB and my group, to analyze data, to provide data to TTAG to inform its work with CMS, IHS, and other organizations. And I'm going to go back a few slides just to provide you an example about why this funding stream for this data project is so important. As many of you know, when you've looked at different reports, if information is broken out by race, ethnicity, you might see some bars for non-Hispanic white population, the African American population, or maybe the Hispanic population. And then there could be another category, and that might include people who are Asian, of Asian descent, American Indian, Alaska Native persons could be included in that other category. And in many reports, there just isn't even another category at all. And so through this funding mechanism, the CMS TTAG data project, we're able to take some of the same data that others use and look at issues related to the American Indian Alaska Native community. And I feel that that's really, it's been very important that CMS recognizes the importance of providing that funding so that TTAG and others can have these results. So using that same funding source, the CMS TTAG data project, we had a Medicare project that was conducted to look at the health status, service utilization, and payments of American Indian Alaska Native persons who were enrolled in Medicare and also registered to use the IHS tribal or urban Indian services. And how this population was identified was that CMS works with IHS to be able to link up the data to identify persons who have Medicare coverage and also were registered to use IHS services. And although they were registered to use IHS services at one point in time, it could be in any one year that they didn't use those services. And so we recognized that in our analysis. I wanted to share some findings from this project with you now. And again, similar to other work, the goal is to improve understanding of the health needs of the American Indian Alaska Natives enrolled in Medicare, and hope that that can be used to enhance services and policies and programs including payment mechanisms that may meet the needs of this population. Here's some information about the numbers of persons included in this particular analysis. We limited the data to people who lived in the contract health service delivery areas, which means that they lived in an area where there was access to IHS or tribal services. We excluded persons who had capitated coverage at any point during the year, because if there was capitated coverage, we wouldn't have a full set of data for them, and we couldn't look at their total utilization during the year we studied, which was 2010. And also we required that they have Part A and Part B coverage. Part A is traditionally thought of as the inpatient component and Part B outpatient. And we did this again so that we would have data for 12 months of the year that could be used to assess their health status, service use, and payments. So just to provide you some highlights of this project, we compared the American Indian Alaska Native Medicare enrollees to non-Hispanic white enrollees who lived in the same geographic areas and met the same criteria for inclusion in the analysis. We found that the American Indian Alaska Native enrollees were more likely to be enrolled in Medicaid, 31% compared to 14%, that's nearly double. And of course, that means they had lower incomes than persons who didn't qualify for Medicaid, but that at the same time, that Medicaid coverage provided them coverage for a wider array of services than Medicare. They were more likely to live in rural areas of the contract health service delivery areas, and they were also more likely to be enrolled due to disability. For example, 27% of the American Indian Alaska Native enrollees were enrolled due to disability, that is, they were less than 65 years of age or had ESRD. In this slide, I just show you graphically some of the information I just shared. You can see that enrollment in Medicaid among the American Indian, Alaska Native Medicare enrollees was at 31%, while 14% of the white enrollees were enrolled into Medicaid. Any questions about the population included in this particular analysis and differences between the American Indian, Alaska Native enrollees and the white enrollees?
There's one question is, were they using the same inclusion and exclusion than were the non-Hispanic white population were only included if they utilized the healthcare facility closest to them?
So I'll go back to the slide on the inclusion criteria. And yes, we use the same criteria to identify the white enrollees as the American Indian, Alaska Native enrollees. And I think that's the benefit of using a national data set like the Medicare data, is that we can draw those comparisons. It's kind of similar to the American Community Survey data, where we can look at healthcare coverage among the American Indian, Alaska Native population and compare it to other race ethnicities. And so what we did is we identified where they lived using state, county, and zip code data, and identified who lived in a contract health service delivery area. Then we looked at their enrollment information to see if they had Part A and Part B coverage throughout the year or the months that they were alive, and that they were enrolled in a capitated plan.
Perfect. Thank you. That actually answered the second question of the, what percent of those had Part A and Part B. So thank you again for that.
Right. And the reason why we wanted Part A and Part B coverage is because we wanted information on their outpatient utilization, but also the health conditions that would be recorded on those claims. Then we can determine, did they have diabetes, end-stage renal disease, and other health conditions. So this slide shows some information about the disease burden. We found that the American Indian Alaska Native enrollees had higher rates of diabetes. Nearly 40% of the enrollees had diabetes, and that was 1.6 times that of the white enrollees. And this rate was age adjusted to the white enrollees. Excuse me. We also found that there were higher rates of end-stage renal disease. 6% of the American Indian Alaska Native enrollees had end-stage renal disease. That's 3 times that of the white enrollees. We also found that the American Indian enrollees had higher mortality. That is, a larger percentage of them died during the year 2010 than did the non-Hispanic white enrollees. And just to show you graphically what that meant, here you can see in a pie chart that 39%, nearly 40, of the American Indian Alaska Natives had diabetes, and 24% of the non-Hispanic white population did. And to show you graphically what we meant by higher rates of mortality is that when we controlled for differences in age and gender, approximately 6% of the American Indian Alaska Native enrollees died during the year, and that percentage was 5% among the non-Hispanic white enrollees. So the mortality among the American Indian Alaska Native enrollees was about 20% higher. And you can see here, when we looked at the age distribution of the Medicare enrollees, that they're dying at younger ages. Their data is the dark blue bar, and the white enrollees are dying at higher ages. There's 2 issues to think about: the percent who died and the age at which they died. Any questions about the health status differences or disparities before I present some findings concerning health service utilization?
There's a question about how these numbers change, for example, among diabetes rates for enrollees. If you're looking at people that are only dually eligible between Medicaid and Medicare.
Good question. I know we did see that being dually enrolled did significantly influence rates of mortality. And we have a more comprehensive report coming out that describes the influences of these different factors.
And then one further question, kind of for the health economists in the room. What are the services with the highest utilization rates, and is there anything in these data that speak to costs, health costs?
Right. Let me talk a little bit first about hospital inpatient services as an example of the utilization data, and then I have 2 slides on payments.
Thank you so much.
It was a great lead-in to the next slide. So we can see from the data that the American Indian Alaska Native enrollees had a higher inpatient admission rate. The rate is the number of admissions per 1,000 adults. So among the American Indian Alaska Native population, it was 385 admissions per 1,000 adults, and that was much higher than 301 among the non-Hispanic white enrollees. In addition to, so I think that tells us, are there opportunities to enhance access and reimbursement and funding for outpatient services that potentially can prevent some of those admissions. So we used a nationally recognized algorithm to identify potentially preventable hospitalizations. It includes some hospitalizations that might be due to short-term or long-term complications of diabetes, amputations, pneumonia, some of the conditions that potentially could have been averted with access to and use of outpatient services. So using this nationally recognized algorithm, we found that the rate of potentially preventable hospitalizations was much higher in the American Indian Alaska Native population. So there are cost implications there. Then we next looked at Medicare payments. And when we looked at payments for the American Indian Alaska Native enrollees, we wanted to think about, some of the characteristics we just thought about. They're enrolled in Medicaid, higher rates of disease. And so what we did is an analysis to control for some of the differences between the American Indian Alaska Native enrollees and the non-Hispanic white enrollees when we looked at payments. And this slide looks a little busy, so I'll walk you through it, and then we can discuss it with, in greater depth. But when we just looked at the average payment per person for American Indian Alaska Native Medicare enrollees, it was $15,000 roughly per person on average per year. And for the non-Hispanic white population, it was $12,000. So that makes you think, oh, then, payments are higher. But remember, we have to think about the differences between the two populations. Nearly 30% of the American Indian Alaska Natives who are enrolled in Medicare were enrolled due to disability. And so that means they were younger than age 65. So when we controlled for age and gender differences between the two populations, that is, we assumed the American Indian Alaska Natives had a similar age and gender to the white population, we can see that the adjusted payment is reduced. When we further controlled for those higher rates of Medicaid enrollment, we see that the adjusted payment is further reduced. And then the other factor that we thought was really important to control for is the higher morbidity burden. If someone has diabetes, if someone has end-stage renal disease, payments for their health services are going to be higher due to those health conditions. So by the time we controlled for differences in age, a good part are due to disability, differences in Medicaid status, and differences in health status, the payments for the American Indian Alaska Native enrollees were lower than that of the non-Hispanic white population. And so some takeaways from this analysis could be that the results document the importance of improving access to preventive services, primary and specialty outpatient services that might reduce the prevalence of some of the chronic conditions and also rates of preventable hospital stays. In addition, we realize it's very important to think about the demographic, cultural, health, and economic characteristics of the American Indian Alaska Native Medicare enrollees in terms of how Medicare programs and quality measures can be interpreted in this population as compared to other populations. And how best to use these findings to inform CMS officials when they're designing programs that will be implemented nationwide, but also within IHS for IHS providers, travel health providers, and urban Indian clinics. So any questions about this particular effort, the Medicare study?
At this time, we don't have any questions.
Okay, so I just want to let people know that we are continuing to analyze these data and working to disseminate findings so that they can inform persons who address Medicare issues throughout the country.
And Dr. Joan, is there, across the different data sets that you presented today, could you speak a bit to access and availability for other researchers?
That's a good question. The Medicare data and the Medicaid data I'm going to talk about now, the national data sets are available through an organization, but the ability to identify American Indian, Alaska Native persons who actually have access to IHS or tribal or urban Indian health programs would not, that flag would not be in those data. And so it would require data use agreements with CMS to be able to access that sensitive data. One of the things that we've been discussing is the importance of trying to make more available these type of data so that other persons can analyze these data to answer other important questions. And so that's something that we certainly are talking about, and it certainly is something that we could follow up on and during another call.
Wonderful. And is there a place that folks can sign up to kind of be linked in and keeping track of your reports going forward?
Yes. Many of the reports are on the National Indian Health Board's website. If you can link to their webpage on the Tribal Technical Advisory Group, and also a number of the documents are available on the California Rural Indian Health Board's website as well. Wonderful. And these findings, as well as previous findings that have been, different reports that have been produced over the years. So having done, completed a lot of analyses on Medicare, we're starting an initiative to analyze data for Medicaid. We plan to take a similar approach, use data from the Medicaid state programs, upload their data to a Medicaid, quote-unquote, national data warehouse. So we plan to access those data so that we can have representation from across the United States. And in this case, we will link the data to IHS data ourselves to identify persons who are who have been registered to use IHS, tribal, or urban Indian health services. We know that, probably 400 to 500,000 American Indian, Alaska Native who use IHS, tribal, or urban Indian program services are also enrolled in Medicaid, and we know that Medicaid is an important source of reimbursement. And so we hope to actually, as part of this project, answer a number of research questions that people have posed to us. One of the issues I wanted to bring up with this project, though, is that I'm going to highlight this section of the document, is that by using data from the quote-unquote Medicaid National Data Warehouse, that we will have national representation. That's the pro. The con is it takes time for all the states to upload their data and for the data to be manipulated so that they can be presented as one data set. And so we will be using data for 2012. So the con of using these data is that we can't use this specific Medicaid data set to answer a question about changes in enrollment due to implementation of the Affordable Care Act. However, we can answer some other important questions. As part of the CMS TTAB data project, other researchers have conducted similar Medicaid analyses and have documented the variation across states in Medicaid payments for American Indian and Alaska Native persons. And so we will definitely build on their methods and their findings in this project. What we plan to do is specifically address some additional issues in this project by using these older data to look at the health needs and service use of specific types of different persons who have specific health needs. For example, we wanted to look at the needs of elders who have chronic diseases or have long-term care needs. We wanted to look at issues related to those who have behavioral health needs, chronic conditions. We wanted to look at oral health service use. And we feel we can use these older data to answer some important questions on these particular health topics. So we're hoping to begin having the data and start the analysis in 2017. Any questions about this upcoming project?
At this time, we don't have any questions.
Okay, so I'd like to provide an overview of another project I'm working on, and it has to do with diabetes. And I thought I'd start off by just describing some of the unmet needs of American Indian and Alaska Native people with diabetes. We know that American Indian and Alaska Native persons are twice as likely to have diabetes than non-Hispanic white adults. And then a series of studies on mortality that were published in the American Journal of Public Health reported that mortality was higher among American Indian and Alaska Natives, and that diabetes-related mortality was found to be 2 to 3 times higher among the American Indian and Alaska Native persons than non-Hispanic white persons. Similarly, mortality due to heart disease and stroke was similarly higher. And one of the other findings was that a large percentage of the mortality occurred before age 65. And that's called premature mortality, and that, say, if someone died of heart disease before age 65, it could be considered premature. And that percent was much higher in the American Indian, Alaska Native community. So given those types of statistics, we obtained funding from the Patient-Centered Outcomes Research Institute to collaborate with IHS and tribal partners to analyze data from the Indian Health Service National Data Warehouse, as well as a few other data sources. We pulled in data from purchase and referred care from the fiscal intermediary that many of the sites use, and we also pulled in information on the cost of providing those services at the different sites that participated in the project. And the goal was to provide information on health status, service use, and treatment costs for persons with diabetes, and then to understand relationships between using services that included education, case management, and advanced practice pharmacy, and health outcomes, and also to provide information that can be used to help patients make decisions about their treatment and enhance services. So for this particular project, as I mentioned, we are using data from the National Data Warehouse from the Indian Health Service. And we have data for 15 project sites. There's at least one project site in each IHS area. And we just show the representation across the U.S. in the map on the slide. This is the second phase. We are currently in the second phase of the project, so I don't have any new findings to share, but I wanted to share some key findings from phase 1 of the project. We found that approximately 15% of adults had diabetes, and among those adults, about a third, 31.6%, also had cardiovascular disease. And as we can see from the previous slide, deaths due to heart disease and stroke were higher among the American Indian Alaska Native, Natives and non-Hispanic white. We found on average that persons with diabetes stayed, on average now, 1 day in the hospital each year. And of course, not everyone had a hospital stay, and some people could have more than one. But on average, it was 1 day per person during the year. We found that the IHS treatment costs for adults with diabetes were estimated to be just over $8,000. And that includes the cost of the services provided at the IHS direct sites or the tribal sites that participated, as well as the cost for payments through purchase and referred care. We found that treatment costs for patients with diabetes but not cardiovascular disease were about $6,000 per year, and when someone had both conditions, diabetes and cardiovascular disease, they were roughly $12,000. So treatment costs for those with both diabetes and cardiovascular disease were approximately 2 times that of those with diabetes but not cardiovascular disease. And then one of the final results I wanted to share with you, going back to cost information, is that while the adults with diabetes represented 14.7% of all adults, treatment costs for those adults consumed approximately 1/3 of resources, 1/3 of all adult treatment costs. So that shows you kind of the impact of the condition can have on resource use. And some of the policy implications are, somewhat similar to those from the Medicare program, in that, efforts to enhance outpatient services to increase access to evidence-based preventive primary and specialty care services is important with regard to reducing the prevalence of diabetes and related morbidity and mortality, and reducing potentially preventable hospital admissions. And some of the ways that the tribal health programs, the IHS direct programs, and urban Indian health programs work to enhance outpatient services are through some of the efforts listed on this slide. So any questions or comments about this last effort that was presented? It's IHS only, so there's no comparison with U.S. data, but it provides a wealth of information for American Indian, Alaska Native to use IHS tribal or urban programs.
Okay, at this time we don't have any questions from our participants.
Okay, well that's the last slide of my presentation. My goal was just to show you a wide array of data that are available for analysis that I believe can be used to answer a number of important questions, and this provides you an overview of some of the data sets and pros and cons of using them.
Phenomenal. Thank you so much, Dr. O'Connell. I think there's so much richness here. A few of the quick remarks that I would touch in on are, I think in the first project that you talked about, when Sarah raised the question about tribal level data and the potential, you talked about the ability to perhaps disaggregate at a state level as giving us some indication both around the tribal level and possibly even the urban system, some insight on that front. And I know that's something that we at NCAI are looking at around the potential for data disaggregation with existing data, as you were talking about, and how to balance the work with existing data in addition to trying to collect new and better data, but recognizing the costs and a lot of the burden that puts on participants in a lot of instances. So I know that I definitely heard that. And this last presentation, we certainly are very interested in this notion of co-occurring conditions and comorbidities. You obviously shared around diabetes and CVD or heart disease, and we had an interesting discussion at our Diabetes Data Institute that what's known, if anything is known about diabetes and its complications, we tend to know about a loss of limb or loss of eyesight, but we often don't think immediately about heart disease. And a lot of the data that you're working with and that is coming out certainly is showing us the risks as well as the impacts around cost and the need for better guidance and supports for our practitioners, our medical providers, and our system. So I'm really appreciative that your analysis is helping us try to understand that better. I also heard, just in terms of the IHS data and the importance of the National Data Warehouse, for those who may be interested in doing additional analyses. But we certainly were excited to hear about the 2017 work looking at some of these different subpopulations and some of their experiences with healthcare. I think across the board policy implications, right? That's our day-to-day work at NCAI. So I just really appreciate the example of modeling how we can go from large-scale data and information about our people and their experiences with a system like healthcare, and take that all the way through the research process to the back end of, so what does this mean in terms of how we shape policy and do our advocacy work in a particular way. So those were certainly some of the highlights and takeaways for us. But I wanted to see, Sarah, if there were any other questions or comments that come in.
Question here is, are you aware of any tribes that currently have a vital statistics department? And if not, is this a step that should be taken to manage tribal data locally that could be more meaningful and usable?
That is a really good question. I know that it's very difficult to use the data that's reported on death certificates without thinking about when the race or ethnicity of the person was recorded. Is that the complete picture? Is that the whole story? Is that accurate? And that a lot more could be done to improve the quality of those data. I have to say, I am not aware of that and can't answer your question about tribal programs, and I wonder if some of the large tribes do. I'm just not aware.
And my guess on that would be to see about whether Chickasaw Nation has, just with their new diabetes center. I know that they've been building some of their data capacity, but I think that's a good question that we'll take note of and see if we can find some information about that over time and see what it would take also to help build that capacity if none currently exists.
Right. And then one of the things you could do just to learn more about what are some of the issues related to mortality and how it varies across the country would be to access the series of articles that came out, the American Journal of Public Health, in 2014 on this very topic, and it provides a wealth of information as a springboard to more to answer more specific questions.
Beautiful. Wonderful. I think we're just about at time, but I want to thank you again, Dr. O'Connell, and really just appreciate your work as one of many data warriors, not too many data warriors that are out there, but just tell you how critical this work is to really inform how we improve our systems and how we also leverage our strengths in ways that can help improve the health outcomes across the board. We hope to share this webinar on our NCAI's YouTube page and with some of our other diabetes projects as well. So please encourage those who may not have had the opportunity to listen in today to go to our NCAI page. We'll certainly send out that link to all those that registered as well as broadly. And we'll anticipate having our next Tribal Data teleconference in January after the new year. So if there's anybody on the line who would like to present or direct us to a resource that others in the network should know about, please certainly email myself or Sarah Katalski, and we'll be putting together a newsletter, our data drum, to come out in between now and January, featuring some of the great insights that we heard today. So thank you, everybody. Happy holidays as they come. And thank you so much, Dr. O'Connell, for your time and for your leadership in this space.
Great. Well, thank you very much for the opportunity to present this work. I feel I'm very fortunate to be able to collaborate with NIHB and the California Rural Indian Health Board on these projects. And also I'm very fortunate to be able to work with tribal health program representatives and persons who work at the IHS Direct sites on the PCORI-funded project to really collaborate with them to analyze their data and feed it back to them and feed it to IHS and work in a collaborative manner over these years on that project. So thank you.
It's so great to hear. Thank you so much. And PCORI is patient-centered outcome research initiative?
Research too, and it's a It's a newer organization that was formed based on the Affordable Care Act. And one of the unique features of this organization is that they feel it's very important to hear from the patient's perspective when thinking about a project, so that what you do is really truly answering the questions that the patients have who ultimately will be using the services or who use the current services. So in addition to a number of steering committees we have a patient committee that meets regularly and really helps drive our analyses by making suggestions about what's important to look at, and also then helps us interpret the data.
Phenomenal. Wonderful. Well, thank you so much again for your time, and thank you, everybody. And we'll look forward to seeing you on our next teleconference here in a couple months.
Great. Thank you very much. Have a good afternoon.
Thank you.
You too. Thank you.
Bye-bye.